Well, good morning, ladies and gentlemen. This morning we're covering uterine anomalies. It's a wide topic that could present in a myriad of ways because there is no rule that anomalies could present with, like in anything else in the anatomy. For the purpose of CME disclosure, I disclosed my relationship with Logic. We have a grant and research. And today I want to discuss with you the uterine anomalies. So evaluation of the uterine anomalies, I will cover how can you evaluate it by 2D ultrasound, 3D ultrasound, 2D sonohysterogram, 3D sonohysterogram, office hysteroscopy, operative hysteroscopy. So 6 modalities can be helpful together. Occasionally MRI is needed, but MRI has a very, very limited role today. So this is our purpose for the morning. A little bit of a reminder of embryology. The Mullerian system comes from 2 sides, as you know. They move toward down, and they move also towards the midline. They have a common wall between the right and the left side. The common wall dissolves. So you can have anomalies because the 2 sides did not move, or you can have anomalies because they moved, but the wall between them did not dissolve. So you still have one cavity, but with one wall in between them. And any degree in between could happen. And hence, you can have one side developing and not the other side. Hence, you can have 2 sides completely separate, known as, like uterine didelphys. Or you can have them coming in the middle, but the wall doesn't come down. When the wall doesn't come down, so like this room and the next room, then you can have a little bit of a septum, would be known as an arc with uterus, and shorter septum, longer septum, complete septum. And I'll show you an example of everyone, but this is the big picture of what we're going to discuss with you today. To try to put it into perspective to you, you have to understand that there is the duct systems, and then there is the gonads. So the gonads start with an indifferent gonad, as you well know, and then goes either way. You will have a testicle or you have an ovary. If the testis is developed because of the presence usually of the Y chromosome, then the testis produces 2 products. One of them is a hormone, testosterone hormone. The other one is the Mullerian inhibiting factor. So what's the difference between the two? The testosterone works on all the systems of the Wolffian ducts to make them develop, to produce all the ducts that you need for the seminal fluid and the sperms to come out. The Mullerian inhibitory factor works on the other system, which is what? Which is the Mullerian system, to make it disappear. To make the Mullerian system disappear. If that Mullerian system for some reason disappear, even a male could have, basically tubes or uterus inside. So what about the ovary? The ovary, there is neither. There is neither, the 2 products that are there are not, present there. So because of the absence of testosterone, you will not have development of the Wolffian system. And because of the absence of the Mullerian inhibitory factor, the Mullerian system will continue, which means what? Means a uterus. So this is the difference between the 2 of them. This is a famous kind of iconic slide to show it from Alfred Jost. Alfred Jost was the guy that worked on that in 1953, and he developed this model, which was really an ingenious model. He tried to figure out what develops what. I mean, how do we end up with where we are? So he said, okay, everyone will start with an indifferent stage. You have here the Mullerian system, which is in the white, and like I told you, there will be 2 tubes and then a uterus if they move together. And then you have the Wolffian system, which is presented to you here in the yellow. So say you have the first scenario here, and I'll go to them in this order, which is a male. So a male would have what? Would have a Y chromosome. The Y chromosome will do what? Will develop the gonad into a testis. It will produce the 2 products, testosterone, Mullerian inhibitory factor. So with the testosterone, the Wolffian system will develop, which is depicted here in the yellow cartoon. Also, it has a Mullerian inhibitory factor, so the Mullerian system, which is the uterus, should disappear in a normal male. So this would be a normal male. Here would be the female. Basically, there is no testicle, so there is no testosterone, and there is no Mullerian inhibitory factor. So the Mullerian system will remain, and the Wolffian system will not develop. Say you take the 4th scenario, the top right corner. This is a male or a female, it doesn't matter, but you have removed the gonads in utero. You have gone inside, and he's done all those experiments on different species, and you have removed the gonads, so you will not have testosterone because there is no testicle. You agree? So there is no testosterone, so there will be no Wolffian system. and there is no Mullerian inhibitory factor, so the Mullerian system will remain. So this is the scenario with the bilateral castration. He did another experiment. He took a male and he removed the gonad on one side. So he found that when he removed the gonad on one side, the part of the uterus that comes from that side stayed. So it means that the Mullerian inhibitory factor is not a hormone that goes out, I mean, it's not something that goes in the blood and then works on the whole system as in a systematic way or in a systemic way, but it worked each side separately. So this would be a male with removing the gonad on this side. So he took the other way, he did a female, and then he grafted the testis on that side. So when he grafted the testis, immediately testosterone developed, and immediately the Mullerian system did not develop. And then finally, he said, is this a function of the testicle or is this a function of testosterone? So he took a female and gave her testosterone, so the Wolffian system developed, but the Mullerian system remained, which means that the Mullerian inhibitory factor is responsible for it. So this is how we figured out that simple slide that tells testosterone does this. This is the guy that did it. His name is Alfred Jost. And he was on the east coast of the US, and he did lots of work. As far as anatomy, and I'm not going to stay on that much, but I want you just to remember landmarks. Like, I mean, they tell you in obstetrics that, fetal heart appears at, say 6 weeks or around that time. I mean, you have to remember certain things, so that when you're doing an ultrasound and the patient is not like, I mean, it's like 9 weeks and you don't see fetal heart, then you think, well, I might be, in a bad situation, correct? So similarly here, you want to know that first, the germ cell migration is the first development in utero. That you have an indifferent gonad, and then you have some germ cells that go into that indifferent gonad. They could develop into a testicle or an ovary. When does the uterus develop, and when does the vagina develop? The uterus develops between 8 and 10 weeks, around 9 weeks, and the vagina about 11 weeks. So anything that you give or take will affect things depending on whether they are not, or they are there or not. So, for example, you give a blood pressure medicine that affects the development of the lungs. Well, if there is no lungs, then that blood pressure medicine could not hurt you today. But if you give it when the baby has lungs, then of course it will be affected. Similarly here, the relevant situation would be exposure to androgens. So if you expose androgens after the organs are developed is different from when you expose androgens before. So all you need to remember from this big cartoon is that the uterus, when does it develop? About 8 to 9 weeks, 9 weeks. When does the vagina develop? Around 11 weeks and so forth. What about the male? The male is more complicated. So for everything else in human reproduction, the female is more sophisticated. But except for this bit of development, the male is more. So first you start with the Mullerian system regression. Otherwise the male would have a uterus. And then you have the testosterone coming out, and this results in a Wolffian duct development. The testicles are there, but they will descend. As you know, the testicles are abdominal, and then they will descend, and so forth. And then finally, the growth of genitalia. So the growth of genitalia is almost a function of the second trimester. The first trimester is characterized by the regression of the Mullerian system. So, and hence you can get different combinations, depending, again, on lack of exposure in the case of a male. So the final outcome will depend on exposure to androgens in a female or lack of exposure to androgens in a male. We're clear on that? Okay. Good. So this is the external genitalia. The top one is the very early stage, and then it goes either way. So it goes on this side to become a female, or it goes on that side to become a male, depending on the exposure. But the same components. I mean, the labia majora could enlarge, could become, corrugated and with rugi, and could move to the midline and then join, and then you have a testicular appearance. So this is how it becomes confusing when a female baby born exposed to androgens come up with external genitalia that almost looks like a male. So everybody looks at each other. It is puzzling. So this is the reason for that. So you might tell me, is it a matter of amount of hormone or is it a matter of time? It is both. So it really depends on both of them. So if you actually expose, we're talking of a female, if you expose her to excess androgen before 7 weeks, you have a penile urethra. If you expose her after 12 weeks, you have clitoral enlargement. If you expose her between 7 and 12, you have basically a situation in between the two. So again, the final appearance depends on the two, on how much androgen, but also the timing of androgen. Because to have a penile urethra, you have to be exposed early. We're talking 7 weeks pregnancy, okay? And remember, we count from like the last menstrual period, so we're kind of... All right, so done with this bit, I'll move you into the next 3 components. I'll run you through some x-rays to show you. This is basic X-rays that we do, and show you the different problems that you can have. So starting straight, the cervix is down, the fundus is up, the tubes are those thin lines for people who haven't, you've seen many of the X-rays. So that should be a triangle in between. So that should be a triangle like that, with the cervix points and the two cornuates. So why is this denting down? Could be one of two things. She could have a septum, or she could have a bicornuate uterus. How can you tell? You tell by three ways. The best is 3D ultrasound in the office. Second is laparoscopy and hysteroscopy in the OR. Third is an MRI. You cannot tell by exam. You can examine all you like. You cannot tell if this is a septum or uterine or a bicornuate uterus. So this is actually happened to be a septum. This is one, Again, this is a septum. The difference between them, between the two sides, is wide, and radiologists they rely on the distance between the two cornea to make the diagnosis and the angle between the two parts. For us, we rely on totally different criteria, and I'll show you those criteria on the 3D in a minute. So what about this lady? This is totally normal. She has, she has some ramifications here. These are normal in the cervical gland because you have pushed some of that dye, it went through the cervix, and then you have a triangular uterus and the cornea on the right and the cornea on the left side. Second one, again, normal triangular uterus, you pushed more dye, so if you see carefully, there is some dye going through the left tube on there and then the right tube. For the X-rays, it's like that. So this is the patient's right and this is the patient's left. It doesn't change. I mean, and most X-ray departments put you an R here to tell you that this is the right side. So this is a normal uterus. What about this uterus? Anybody can tell me if there is anything wrong with that uterus? Well, again, we said it should be a triangle, and then the top should be flat, so that top is dented. We call it an arcuate uterus. What is an arcuate uterus? Is the beginning of a septum. So how do you make that call? You already could draw a line between this cornea and that cornea, join the line, take the midpoint, drop a perpendicular, and measure that. If this is less than 1 centimeter, it is an arcuate uterus. If it is more than 1 centimeter, it is a septum. This is basically the diagnosis there. So what about this one? It looks like a septum. Did we drop the line and so? No, but this looks more than 1 centimeter. How do I know 1 or 5? Basically, how long is the uterus? About 8 centimeters, 7.5 centimeters. An inch or 3 centimeters is the cervix. 5 centimeters is the corpus, and an average uterus. So if this is 5 centimeters from here to there, from the internal os to the fundus, and half of that is taken, then by logic, this is more than 1 centimeter without measurement. But of course, you can drop lines easy, especially now with the software that we have. This is uterus didelphys, meaning she had 2 bodies, 2 cervices. She could have 1 vaginal septum. She could have any combination of the above. The uterine didelphys, usually you don't do anything to it. I mean, you just have double uterus. I mean, you do not have to do anything. If everything is canalized all the way from the tube to the uterus to the cervix to the vagina there, you really do not do anything to it. But usually they're associated with other anomalies. Like what? Like kidney anomalies, renal anomalies, like lumbar vertebrae anomaly, like middle ear ossicles anomaly. These are the 3 commonest anomalies associated with double uterus. What about this one? She missed 1 side. So this is a unicornuate uterus. So the uterus, as we said, should be 2 sides. They move to the middle, they join. Well, the right side is there, but the left side is not there. So this is a unicornuate uterus. Again, what's the management of unicornuate uterus? Nothing. What about this one? Is this a bicornuate or unicornuate? What do you think? Guesses? Any guesses? Don't feel at all embarrassed. Say just anything that comes to your mind. Unicornuate. Okay. All right. I mean, good guesses because there's 2 sides. But this is actually scar tissue inside the uterus. So it is not a uterine, and she's not born with that. She had a baby, delivered, had bleeding, had a scrape. I mean, the uterus was scraped. So after that, she quitted having periods. We did the X-ray. The whole uterine cavity is stuck. But good guesses. I mean, it looks more, more like an anomaly, but it is not an anomaly at all. She was born with, and then if you look also carefully, the tube fills with there. The tube is conical and then stops here, which is classic for that she developed a pelvic infection, and they also closed her tube. What about this one? What do you think? Unicornuate or bicornuate? Fibroid. So again, it looks like a unicorn, right? Like one of those, but really this was a huge fibroid that occupied the right side of the uterus. Okay. Here, what about this one is the septum, but what I want to really exaggerate to you here, see that area there? That's called the interstitial part. This is from where we see when we do hysteroscopy. This is from what you see when you do a laparoscopy. So there is a part in between known as the interstitial part. Very unfortunately, pregnancies could happen in that part. Pretty dangerous situation. Every 3 or 4 months we have one of those. Pretty tricky because they bleed much more. So this is the interstitial segment of the tube. What about this patient? She had endometriosis. We put the dye. And then you can see here the dye is going through the wall of the tube, but is not actually going to the end of the tube and is not spilling. You would have normally seen it as spilling, like I showed you. This is a long name called salpingitis isthmica nodosa. So the isthmus is, of course, the proximal portion of the tube. Salpingitis is an inflammation, but it could be also endometriosis and not inflammation. Nodosa because it looks like shots on X-ray, like nodes on X-ray. So this is the salpingitis isthmica nodosa, which is usually seen with endometriosis. And is characterized by bilateral proximal tubal obstruction. What about this one? Also, she has isthmic occlusion of the tube. What about this one? She has a hydrosalpinx here. You can see massive hydrosalpinx. And the more you put the dye, the more it becomes tortuous, convoluted, and so on. This is the uterus, but its uterus is anteverted. So if they pulled with the tenaculum down on the cervix, they could make it straight, and that would have looked a triangle. We did not pull enough. So, but this is a classic hydrosalpinx on the tube. So this is the two, like this is the X-ray. All right, we've covered with you the anomalies. We've covered the problems inside, which are typically one of 3 things: either fibroids, or polyps, or scar tissue. There is nothing else that could happen inside the uterus that developed other than what she was born with. What about the 3D part? The 3D part here is classic. So this is an arc with uterus. So why is it an arc with uterus? Can you tell me why, based on what we said at the beginning? If you draw a line there, and then you take the middle point of that line, draw a perpendicular, this would be less than 1 centimeter. In this case, I think it's about 1 centimeter, but this would be an arc with uterus. Look at the next one. Same thing, arc with uterus. And then look at this one. This leaps inside, looking like rabbit ears. If you draw the line from here to there, and take the midline, and then drop here, that is definitely more than 1 centimeter, because again, from here to there is 5, so you really use 3. So this is a uterine septum there. Again, another uterine septum. So this is a 3D. Why do I say this is a uterine septum and not a bicornuate uterus? Because the top of the uterus is straight. So in the previous pictures, we have hidden that. So you can't tell. It is not that you don't know. You cannot tell. Because if it is straight, then the vision is within. But if this is a heart shape, you look from the uterus from the top, and the uterus is a heart shape, then this is a bicornuate uterus. So this is the difference between the septate uterus and the bicornuate uterus. How can you tell? 3 things. Number 1, 3D ultrasound. Number 2, laparoscopy and hysteroscopy at the same time. Number 3, MRI. Can you tell by exam? No. Can you tell by 2D ultrasound? No. Why you can't do that by 2D ultrasound? Because the 2D ultrasound, so you take, like, you look at the sagittal plane, the uterus looks like that. You can see that part if it's at the top, bent inside or not. But with the 3D, we take different cuts. What cuts? I will show you in a minute. How does the 3 kids do? So this is, again, is a septum here. This is the endometrium there, this is the endometrium there, and so on, 3D ultrasound. What kind of section is that on the ultrasound? This is called a coronal view. And I'll show you the views so that after a while you'll find that you're very comfortable when you just look at them as you're walking in the room. You can say, well, this is this one. Again, the top is straight, so this is not a bicornuate. It dents down and dents more than 1 centimeter, so this is a septum. This is, again, a septum, but a very long one. And again, this is a septum. But here, it bends some. So this is in between. Again, the anomalies do not have to abide by the rules. I mean, they could come any way they like, and they can be confusing, and many of them are very confusing. Many of them, after we do all the tests we know, we still couldn't figure out exactly what is happening. Again, a septum. Here, I want to show you that I put the cross above that line. So this is the line, this is the cornea, right cornea left. You can draw the line here, so I should put that cross here. But the cross is here, because really the cavity should always be cathedral looking, should not be chandelier looking. When you go inside the cavity should be away from the cornea, not down from the cornea. If you say down from the cornea, that is abnormal. How much clinically does this abnormality affect? I will show you in a few minutes. Again, this is a longitudinal septum here. I put the cross higher, right? But why did I put it higher? For example, this is the opening of the cornea, and this is the opening. I could have put it here. But if you see the line at the top, now the coronal view have been dragged down so that you can see the top is there. So this is the length of the cell. So when you cut, you are going to cut like 3 or 4 centimeters, which is a significant amount of tissue because it's inside the uterus. So we're done with the 2D and 3D of, of the 2D or 3D ultrasound of uterine anomalies. Here is a combination of a few things that I want to show you. So, for example, this is a transverse view. So we said there is a sagittal view, and by sagittal view, and I'll show you in a minute with the sonohistogram, sagittal view is cutting like that. So if somebody is like that and you cut from this to this way, that's a sagittal view. If you cut that way, it's like coronal view. And if you take uterus, which is a pair, and slice it and take that top off, that's a horizontal view or transverse view. So this is a transverse view. What does it show you this on transverse view? This is endometrium, myometrium, this is right side, and this is the same here on the left side. So it could be septate, could be bicornuate. This happens to be bicornuate, and I will show you in a minute why. This was her, the MRI from the bicornuate. This is actually from Wayne State, from Dr. Pichek, my co-editor. And this is a bicornuate uterus. Why bicornuate? The MRI shows you clearly here that the uterus is a heart shape, right? If this was a straight line and there was just a septum, that would be septate uterus. But the MRI is showing you here. You have to have good MRIs and good cuts. I mean, if you because otherwise it becomes very confusing. She has one cervix, as you see, the two merge together, and she has one cervical canal. So having one cervix and double, cornea is to bicornuate uterus on an MRI of the pelvis. Again, an MRI on the pelvis showing you a bicornuate uterus, but different cut. So the first one was similar to what we are used to as a coronal view, which is that view, like that. But this one, the next one, is a different cut showing you bicornuate, and you can see the iliac bones on each side of the stuff. Again, a bicornuate uterus. Bicornuate uterus. And different cuts of the same thing. So here you almost have like a coronal cut. Here you have a transverse cut. And here you have what it would be like a sagittal cut. So you can see from the sagittal, you can tell, because the sagittal is like that. You can go this way and just get one side of the uterus, or you can go that way. So if you, for example, insert a vaginal probe and get the whole length of the uterus, you can get the right side or the left side together. You can only do it if you are keeping in mind and you swipe from the right to the left. But this is a coronal view. So we agreed what's a coronal view? I mean, even if we end up with that today, that's very valuable. So coronal view, you're cutting like that. Sagittal view like that. I mean, like if you slice me in the middle from top to bottom, the cervix would be down, the top would be here. And then horizontal is like that. So the uterus sits like a pear with the cervix down, the fundus at the top. And if you slice it off, that would be a horizontal view or a transverse view. So I'm giving you here the 3 views and showing you that the top one showing definitely the evidence of either a septum or bicornuate. Can we tell? We can tell because the top is not there. We know I put here bicornuate, but we have completed the case. But looking just at like that, you can say it could be septate, could be bicornuate, for the purpose of clinical management and also for the purpose of exams and so on. Here we put some fluid inside the uterus. The fluid went into the 2 cavities. So when you see 2 cavities, what kind of a view is that? That's a transverse view. And there is a right side and the left side. Could be a septum or could be a bicornuate uterus. Again, here this is a bicornuate uterus in what we call a rendered view. And this is a septum on a transverse section of the uterus. This is again a long septum, thick septum. You see the septum starts here thin and then branches out thick, and here she has a bunch of adhesions and polyps. Not uncommon at all. Every day we do that. We see a significant amount. This is a uterine didelphys. This is a MRI T2 cut showing you a duplicated uterus with the right side very dilated and the left side is normal. And again, uterus didelphys, and then the same uterus didelphys here. So these are the MRI figures of all those bicornuate and uterus didelphys, again with the uterus obstructed by the vaginal septum. Problem with those kind of combinations is that you do not have to have the 2 parts coming parallel to each other. You can have the one side coming and then the cervix joins the other side. Could join it at an angle, could join it transversely, could join it below the vaginal vault or above the vaginal vault. So if a joint is below the vaginal vault, you put a speculum, you see two. If a joint is above, you can't feel, you can't examine and say, oh, I feel another cervix. It's impossible. No, you can do another cervix if it is developed down enough. Okay? So I think we clarified that. Another cut here showing you a uterine didelphys, and this is the cut at the level of the cervix. So you can see a larger cervix here and the smaller cervix on the left side. Again, uterine didelphys. This is what? Unicornuate uterus, and this is a rudimentary horn. So this is the normal size, and then this is just a rudimentary horn. Rudimentary horn means it does not have a communicating cavity, does not have enough endometrium inside it. This is unicornuate, but one side is obstructed and not communicating to the other. So again, I told you that there's two sides and the join and the wall melts and all this sort, but you can have a remnant of one side that does not join the other. This is also unicornuate, which is the good side here, and this is a non-communicating rudimentary horn. Again, unicornuate with a coronal cut, and that's this side, and then non-communicating rudimentary horn. Unicornuate with non-communicating rudimentary horn. And this is a simple arcuate again. Okay, unicornuate uterus. So we're done with that part. The third part I want to show you today is sonohystogram. So what is sonohystogram, or saline infusion sonohistography? Saline infusion sonohistography is putting normal saline inside the cavity to show you what you would like to see, but your imagination could not develop it with regular ultrasound. We put a large series. This was the book we published in 2010 on ultrasound in reproductive medicine, and this series comes from Denver in Colorado, and they're actually beautiful series. Showing you first here, saline is being put inside, and there is two black spaces. So this is two sides of the uterine cavity. Could be septum, could be bicornuate. Okay. This is a longitudinal. Longitudinal means what? Means sagittal, cutting from here to there. So this is the fundus. This is the cervix. For me, I keep it always this way. I do not change the topography of scanning, because if you change, then you have to think. You don't want to think. You want to walk in, and it's already recording. I mean, you know in your mind what it is. So the fundus is there, the cervix is there. The catheter goes from there. Doesn't matter which kind of catheter, but you need to have a balloon to close the cervix, otherwise the water will fall out. If you put the balloon is here, and you fill it with water, so this would be nice. This is anterior, this is posterior. This is fundus, this is cervix. Can you tell right or left? You can't, right? Because this is 2D. You just could tell fundus and so on. We filled it with water. The lining is normal. The lining is normal. You agree with that? The lining is normal here. Let's look this one. The lining is filled with some stuff. So it could be what? Could be cancer. The first thing that comes to mind. What was it? It was just the end of the menstrual cycle. She was the third or fourth day of the cycle, and this was just a blood clot. So we brought her back 3 days later, and the cavity was perfect. So don't jump into conclusions, and always have an opportunity to come back on yourself and take your time and review it. Of course, somebody like that is, why is he having a sonohystogram? Because of abnormal bleeding. Then you find this irregular mass in the uterus. Once the word irregular becomes reported, everybody thinks it's a mass inside the uterus with irregular borders. So it is endometrial carcinoma. Now, this was just a simple blood clot. If you want to see the lower part of the uterus, you have to deflate the balloon and pull it out. And look as you deflate it and pull it out. To be able to see, you have to have more than a cut. Because I showed you the first one, and you can tell anterior and posterior, and fundus and cervix. Can you tell if this is right or left? You cannot. But this one, we took a coronal view. So coronal view is like that. And this is the right, this is the left, this is a fibroid, and this is a polyp. The fibroid is inside the uterus. So it means that when we do surgery for it, it will have to be a hysteroscopic surgery. So you plan your surgery based on your find. But you cannot go in open to all possibilities, because in the OR, you do not have ultrasound usually. You can bring in ultrasound, but it is cumbersome. So in this situation, you want indeed to have a good look on a coronal view with a fibroid and a polyp. This is actually a sagittal view. What do I mean by a sagittal view? Fundus is there, cervix is there, and there is something bulging there, and this is submucosal fibroid. There are 3 types of submucosal fibroids. First, fibroids could be in the wall, called intramural, could be outside, called subserosal, or could be inside, called submucosal. The submucosal could be 3 grades. Could be type 0, type 1, type 2. So type 0 if they're all inside the cavity. I mean, if they're hanging on. So you can go inside and pull it on a pedicle. Type 1 is that the majority of it is in the cavity and less than 50% in the wall. Type 2 is more than 50% in the world. So why are we fussing about all that? Because if you take a type 2 and you try to remove it hysteroscopically, you will end up with a big crater inside the uterus, and you open the uterus from within and then have to go and do either a laparoscopic or an open procedure. So you have to know what type of fibroid you're dealing with. We do 99% of the fibroids with laparoscopy, but we are prepared both ways, hysteroscopic and laparoscopic. You cannot go in as a patient with 7 or 8 fibroids and then start laparoscopic and then find that 2 or 3 are inside and do not complete it. And vice versa, you cannot go in to complete it from all within and then find that 3 or 4 of those fibroids are actually in the body of the uterus, and you have to make a cut and remove them as well. So what about this one? What kind of cut? If I leave you that you look at the cut, just tell me this is transverse or sagittal or coronal. I'm very happy today. What kind of cut is that? You have 3 choices: sagittal, coronal. Very good. Horizontal cut. So horizontal cut, what you can see right and left. You can see anterior and posterior. Or you can see fundus or cervix. Otherwise, you are a prophet. But so what is this one? What is the lesion coming from where? Anterior or posterior? Posterior. Right or left? In the middle. So this is a posterior fibroid. Pushing in the cavity or not? Yes. What about this one? This is a tough one. Yeah, exactly. Excellent. This is a sagittal, but she's tricky. Why she's tricky? Because her uterus is retroverted. I told you that I keep the same. Cervix here, fundus there. But where is the fundus here? We didn't change the plan. Just as uterus is turned upside down. When you do a bimanual, you think she has a fibroid in the behind you. This is not a fibroid. This is the whole uterus is tilted backwards. So when you do a bimanual exam, this is the fundus of the uterus. As it happens, this will be the anterior wall rather than the posterior wall, right? Because this is flipped back. So this is large polyp on the anterior wall and a smaller polyp on the posterior wall. So this is just a retroverted uterus with 2 polyps. So what kind of cut is that? Yeah, sagittal. What is the lesion here? I mean, you have 3 lesions, nothing else. You have a fibroid or a polyp or a scar tissue. So this is a polyp. Why is this a polyp? Because the fibroid, remember, most of the time fibroids are just round things like that. So polyps is that. What is the blue and red? We're doing Doppler. Every polyp has a vessel. So it is called the feeder vessel. All right. So this is a polyp from which wall? Anterior or posterior? Anterior. Huh? I mean, posterior is here. Anterior is there. Good. So this is what view? Coronal view. What is coronal? It's like the triangle here, right? And so on. So this is right, this is left. So what are the 2 lesions? The rounded is a fibroid. The other one is a polyp. So the fibroid comes from the left lateral wall near the fundus, and then the polyp comes from the other side. This is what view? Sagittal. What is the lesion? Again, fibroid and polyp. The long arrow is the fibroid. Where is it? It is submucosa. Part of it in the wall. So you draw a line here and see, is 50% here or 50% there? It looks like more than 50% is here. So this is type 2. So this is not one that you're going to do using a hysteroscope, because by the time you take that, if you keep shaving, then there is no anterior, there is no uterine wall. I mean, it's gone. But you do it with laparoscope. You cut the top and you take it out, and then you throw a line of sutures there. This is a typical case. Patient comes in with bleeding. So the first thing you do is an ultrasound. So the ultrasound shows you that the lining is thickened. The lining thickening is 14 millimeters. So here is Doppler, showed you a feeder vessel. Now we do a saline infusion sonohistogram, SIS, with some fluid, show you that the polyp is still here, filled almost all the cavity. And then finally we do an office hysteroscopy, and the polyp is coming down in front of you. So the patient comes in, and in 1 hour, you have figured out what's the problem. You don't need MRIs, you don't need all of that. I mean, she comes in, has an ultrasound, she has abnormal bleeding, you do ultrasound, it is thickened, you move on with saline infusion and sono and office hysteroscopy as well. This looks like a saline infusion, but it's not. It's endometrial cancer, but the central part is degenerated, so it looks like it's fluid. It's not really fluid. This was not saline, this was regular ultrasound, and she had endometrial cancer. This was a breast cancer patient, and most of the times if breast cancer are estrogen receptor positive, they are put on tamoxifen. So with tamoxifen, those patients could have endometrial hyperplasia or even endometrial cancer. And sometimes more tricky cancers, they have sarcomas under the endometrium. So even when you do hysteroscopy on a patient who's bleeding abnormally with tamoxifen, you could see a normal cavity because the cancer is behind that lining. So you have to be very cautious with that. So if you guess this one, I'll give you the ultrasound book today. Without, of course, reading. So this is the cavity. I'll tell you, it's a horizontal view. What is that? And it is not a uterine septum or bicornuate. Or like that. Any guesses? So I better say it quickly before you get the book. So this is adhesions from the front to back. So this is the anterior. I told you this is a horizontal view, anterior, posterior, and these are adhesions from the front to the back. So this is known as Sherman Syndrome. So what's the story here? As I will show you 3 or 4 of those. She was pregnant, she miscarried, 8 weeks, she bleeds, she comes in, first D&C, she goes home, she calls you back, she's bleeding again, she comes in, second D&C, she calls you back, she's bleeding, comes third time, you are determined that this story is over today. So you do a curettage that is the most thorough curettage in the world. She ends up 9 months without a single period and she's not pregnant. This is Sherman Syndrome. All right? So this is the classic Sherman Syndrome. Could be very tricky to deal with, as I will show you actually. I will show you some videos of removing the most severe degrees of Sherman Syndrome. Like you go in and there is no cavity, and you start with that, and you end up with a normal, beautiful endometrial cap. This is a sagittal view. The caster is coming from the cervix, which is to her right here, and this is an Sherman Syndrome. The adhesion is front to back there. Again, this is Sherman Syndrome. The same thing. The patient has spontaneous miscarriage, had 1 curettage, and after the curettage, she quitted. The period became, very spotty and light. She has 2 or 3 days of minor spotting, and you can see the sagittal view, and the other one, you can see also the adhesions joining the 2 sides. So it looks like a septum or the bicornuate. It is not. It is just adhesions giving you the impression of a septum. This is the true septum, and this is sonohistogram. What kind of view is that? Coronal view, exactly. Why corona? Because it is like that. So you have, again, the transverse is like that, the sagittal is like that. So this is a corona, right septum, right side, left side, the septum in the middle, and then on the right side she has a polyp. You can't see the polyp until you put water, because before that you just see the whole thing is white and thickened. Until you put water, so the polyp comes out in the right side. Okay, so this is a saline infusion, but 3D. So we took 3 looks at it. This is the corona, this is the transverse, this is the sagittal. So why is it? It's very useful. So you look here. This is the anterior, this is the posterior. She looks like she has a posterior wall fibroid. Is it right or left? You can't tell. But you take the corona, it's coming from here. So this is definitely her left. Like I said, this is her right, this is her left. So now you can tell she has a submucosal fibroid, left upper posterior. All right. How can you be so precise? By taking so many cuts. You cannot look at the 2D ultrasound and say, I concluded. So we're done with 2D ultrasound with that. I will show you some of those, and I wish even some of our faculty were here, because this is the most clinically kind of delicate topics that you do. Because when you get a report, most of us take the report for its face value. You get a report, pathology says cancer, you say, okay, I send it to the oncologist. You get a report saying, this is, pathology of, just benign fibroids, you believe that. You get the pathology saying cavity is normal, tubes is normal, you say, okay, hallelujah, she doesn't have any. Well, I'll show you that all those reports actually mean nothing. And you have to integrate information. Why is that? This is the first case. I'll show you 6 clinical. These are patients, and I'll show you at the end the cartoon of every patient, showing you the different assessments and how that you concluded the opposite of what the first guy concluded. So this lady was sent for an X-ray because she doesn't have babies. She has primary and peripheral. So the X-ray was that they put in some dye here. Again, they put a catheter. This is the tube. The tubes are filling and spilling, so everybody is happy. There is a dent at the top. So they thought, well, could this be a septum or an arcuate uterus? So they put more dye. As soon as they put more dye, it disappeared. So this is a normal triangular cavity, bilateral patent tubes, bilateral fill and spill. You get a short report to tell you she is 10 out of 10. So you send her home with a prescription of something and tell her come back in 6 months. You're really total mismanagement. So take it a deep step. The second step, here is an ultrasound. What kind of ultrasound? 3D ultrasound. What kind of cut? Coronal cut, and then I join the 2 dots. You put here, this is of course not a normal ultrasound, right? You agree. So at least this is an arcuate and could be septum, depending on how deep the distance between the 2 crosses. So we take it as a further step, and we put some water or saline or any fluid inside her uterus and repeat the same 3D ultrasound, saline infusion. And what is it looking now? again, septum or arcuate. But this is not the normal HSG. This report was normal. So if you stop saying, but if her HSG is normal. So a negative HSG, in the majority of time, is a false negative. And then here we do hysteroscopy in the OR. She has a huge septum, and she has a polyp on one side. So the polyp was seen actually by the X-ray, to give them credit. If you look at that X-ray, that's a polyp, or suggestive of polyp. And then you look at this one again, suggestive of polyp. And then here, this is the hysteroscope. If you don't believe me, say, well, what is this septum? This guy is just, saying stuff. This is, well, we just deviated the hysteroscope to her left leg, so you get the right cornea. When you see the right cornea like that, and it's coming towards you, I told you this should be cathedral. This is coming towards you so much. You say, well, am I sure or not sure? This is the edge of the septum. The right edge of the septum sits like that. It is just wide enough that you cannot, unless you pull out, you cannot get the whole view. So this is, we're cutting the septum. You see how much tissues we're cutting? This is a loop. This is one of the resectoscopes, and we're cutting the septum, and the cornea is still there. So we've cut about a centimeter, and we're still working on it. This was reported as normal hysterosalpingogram. And this is the end of the procedure. We have cut the septum, a huge septum. Most of those patients present with recurrent pregnancy loss. They could present with infertility. What are the chances that these patients miscarry? If they are not corrected, 80%. What are the chances that they continue on their own? 20%. So 20% of people, somebody could have a train accident and go away, get away with the pregnancy, no problem happen, and somebody slips one step and miscarry. Similarly, you can have the worst septum, worse and so on, and pregnancy goes on normal. And then the next one have a small septum, and why is it that? It just is a bit of luck depending where implantation has occurred. So you got the idea from this one. Let me show you another one. This one, the X-ray, this time, showing you a big cavity here, right? We wanted a triangle. We wanted a full triangle. We need our triangle. Well, there is no triangle here, so this is the... we did another one there, and the fundus showing you... we put more dye, and the fundus is still showing us some arcuate uterus. When we do a 3D, our gold line, we like the 3D and so on, it's normal. She doesn't have an arcuate. So the 3D is normal, while the X-ray, which is the most crude of investigation, is showing you it's abnormal. So in this situation, the X-ray was correct. But let me take you through the scenario. This is a filling defect. Probably was a polyp. But at the end when you take her to the OR. So here we put some water and do a saline infusion sonohystogram. And then here, this is inside the OR. It's not very clear, but this is a septum. And then here we try to clear it. And then eventually we cut that septum away. Again, this is a third case showing you what do you have here? Arcuate or septum or polyp or fibroid? Arcuate. Why arcuate? Because just a sedent. We put more dye, it didn't correct it, still an arcuate. So the X-ray reports come saying it's an arcuate. Of course, if this is a clever X-ray, if not, a reader, if not, he would say, well, it could be a fibroid, could be this, could be that. When you state so many things, you're confusing also the audience. You have to focus, is it this or that? You can't just say it could be, everything in the book. All right? So this is a 3D showing you also a arcuate uterus. So both agree, 3D and ultrasound. Again, 3D here showing you measurement. So now we put our two crosses. We took the midline, we dropped the perpendicular, we measured it. This was 4.1 millimeter. So is this an arcuate or a septum? Arcuate. Why arcuate? Very good. And then we go inside, we're totally wrong. It is a very, still very steep level. Of course, this is thickened from endometrium. The endometrium thickening depends on two things. Depends what time in the cycle, and also depends on if she's ovulating or not. So you take a patient who's 50 years old, has a thin endometrium, or somebody who has polycystic and has not had a period for 3 months, you get very thick endometrium sometimes. Okay. And here we cut it, and you can see when you're cutting, this is fibrous tissue. They never bleed. They never bleed because they're fibrous tissue. So if they are bleeding, then you're not cutting in a septum. If you're bleeding, any degree of bleeding. And how do we know that we're almost done? Because we take it to the fundus, and the fundus bleeds. It doesn't bleed when you're putting too much pressure in the OR, because we use 80 millimeters of mercury, and we can increase from 80 to different levels. We use a setup that we control the volume and the pressure. And that's, in my opinion, the best thing you can do. But if you're going to have a pump and somebody does it and the guy walks away and all that stuff, like sometimes happen,
you cannot do surgeries. I mean, you can do all you like to look, but if you're going to cut, then you have to have a calculated amount of pressure and a calculated amount of suction. The pressure that we use is 80 millimeter mercury, and we can go up. Can go up to different levels depending how comfortable you are. And when you suction also at pressures that varies from like 200 to 800. The more suction you do, the more useful it is if you're removing tissue. But also you will have more bleeding because it pulls the blood out of those veins. So this is the end of this. We have divided the septum there. So this is another X-ray showing you possible septum or arcuate uterus. Again, we put more dye. It's almost normal now. So the guy is going to report it as normal or abnormal. He usually reports it as normal. Because remember, those patients are not complaining of anything. They're just coming because they told them, oh, I had a couple of pregnancies and I lost them. They tell her, we're so sorry, your X-ray is good, congratulations, you go home and you'll be happy. You know? So, but you look at that X-ray. This is a 3D ultrasound, normal. 3D sono, normal. We go inside, she has a small septum. How do you know that this is septum? You see that pink? That pink is the intermediate. The end of the cut is where is there. The distance from the end of the cut to the pink is what you have actually cut. So at the end, you want to say, how much did I cut? So I dictate that in the note. We have cut 2.5, 3.5, whatever. It's a visual estimate. Do I have a measurement? You could. But most of the time, you have to get out your instruments and measure. But you have a visual measurement. So if you measure something like that, that's, of course, a short septum. So what would be long? Would be sometimes to here. Do we do that? Yes, we do. And I'll try and show you some of those today. Another patient showing you. Again, this guy decides to put the L on the left and right. This is the correct way. They should put right and left. But most X-ray departments keep it the same. So this is an X-ray. This is what? Arcuate. What kind of cut? Coronal cut, coronal view. 3D sono show you also an arcuate. We do the line. We take half. We measure it. How much? 6.9. So 6.9 millimeter is less than 1 centimeter, so it's still not a septum. We go inside, and it does have an arcuate, and we cut that arcuate uterus here. And you can see here, this is the right side, this is left side. After 10 of those, your eye will get inside. To the point that actually, even our fellows come to some of the cases. You've seen so many, some of my colleagues and so on go in and say, oh, this is perfectly normal. And then, of course, it is totally abnormal. Your eye has to get used to it. And I'll show you those. I'll show you also on other brain rounds, like ovarian problems, that you look in and make a diagnosis. Not by making a table, this is complex and this is septated. And so you look in and make an impression of what it is. What is this cavity now? HSG, normal? Yeah, normal. We agree that this is normal. 3D showing you an arcuate. 3D showing you again an arcuate. I'm sorry, not 3D. 3D sonohistogram, saline infusion. So showing you an arcuate. We make the measurement 6 millimeter, 6.1 in this case. We go inside. It's a bit bigger than that. This is a very significant one. Do we cut it? Yes. And here we're cutting it with the loop, and you can see the part that is cut and the part that is not. That loop is very small, so it cannot cut the whole septum. You take multiple bites. It's like, you take like 10 bites there, and then after 10 bites, you get done. The problem is that the bites are not a straight line. They make an instrument that you can kind of draw it, and there is, this is another topic, the variety of instrumentation. You can do it from laser to monopolar electricity to mechanical rotation. There is lots of things, okay? Again, X-ray showing you normal cavity. X-ray here showing, 3D ultrasound showing you arcuate uterus. 3D, again, saline infusion showing you a normal cavity. You go inside, what do you think? The cornea is tucked there. Why is that cornea tucked? The cornea should be below the fundus. The cornea should never be above the fundus. If it is above the fundus, that means it is a septum. So this is a septum, and here it is. We're cutting it, small corneal erosion. And this is after the division. How do we know we've divided it right? All this is fibrous tissue, just strands of fiber. You cut it slices. But we put so much water so that it puts them on a stretch. If you want to cut this shirt and it's crumbled, it's very difficult. But if you do it like that and use your scissors, it will cut in one cut. Again, last one, I think. X-ray showing you an arcuate uterus, but the two sides are not equal. The right is different from the left. And then we put more dye. It almost becomes normal. We look at the X-ray. It shows you a very small arcuate. We look inside, and it does indeed. This is the right cornea and the tubal ostium, and she has a septum there, small cornea and the tubal ostium, and then that is the panoramic view. Here, before I conclude and show you some videos, I want to put, this is the same patient. I put all the views on one cartoon. All the views give you an impression. So this is the one that I showed you at the beginning was abnormal. When we put more dye, it was normal. We did a 3D ultrasound. It shows you a septum. we did a 3D serine infusion septum, and then you go in, she has a massive septum there. So this is number one. This is the first one that alerted us that relying on reports of HSG is totally misleading or totally deceiving. Not because of bad intention, it is because it's a very crude way. So HSG is a good test. It has a very high false positive. So those statistical things mean a lot here. I mean, if it's high false positive, you tell the patient you're good. This, for example, could be dangerous in oncology, if you tell the patient you're good and he's not. But in this situation, it is also dangerous because she will not get pregnant or she will lose the pregnancy. Number two, X-ray showing you here, massive arcuate or septum, normal 3D, normal serine infusion, straight line, and then we go inside, she has a septum. So the X-ray was right. Why is that? I mean, many explanations. Could be that the septum was taking it all down and the polyp taking it a bit more down, so it ameliorated the effect of the septum alone. Maybe, I don't know. Again, showing you here a mild arcuate, very mild arcuate on the 3D, very mild arcuate, and then as we're cutting, you can see in front of your eye that if this was, so you might tell me, why? How do we know this is septum? If this was the fundus, this would bleed like no tomorrow. I mean, remember your classical cesarean section, and just you put your needle, you come out, by the time your needle is out from the other side, this side is bleeding. So if this was a fundus and you're slicing the fundus, you will have some bleeding, so don't worry, you will be able to tell. Again, the four views here, very mild arcuate, normal 3D, normal serine, and then here we cut it, but it's not much. I mean, this is the top that we've cut, and this is the beginning. You see here, this is the normal endometrium. This is what's cut. This was flat and close together. And then here again, arcuate, and then septum there. You like that? It shows you there, and you will see it more in the videos. Normal arcuate, almost normal HSG, arcuate on 3D ultrasound, arcuate on 3D serine, and then septum, and the same here, 6 millimeter arcuate uterus, and then septum there. And then final one, showing you the two sides are not the same. Okay, so let me do that. Let me escape. So I want to show you, I mean, I'm done with the lecture. I want to show you some cases that we have done. So this is the first case. This is a septum. So this is operative hysteroscopic. This is the septum. This is the right corner. This is the left corner. Okay? So and then you will see that at the end of this procedure, the cavity has become normal. Of course, this woman has how much chance of carrying a baby to end? 0. I mean, placenta will stick either here or there, either or there is no blood supply. This is a bunch of either fibrous or fibromuscular. So we go in, we look. This is the posterior wall. This is the septum. You will see better in a minute. And then we are trying to go from one side. So this is the instrument that we use, and we're going from this side. So the septum is here, and we're going from the left side, and you will get it clearer in a second. When you apply suction, like I said, it pulls in the fluid and the water gets there. You stop your suction, it clears it, and here we are removing the tissue. It removes the tissue by a dual mechanism, but this is a topic in its own right, the different mechanism of removing the septum. And these are some polyps on the surface of the septum, so we're taking them as well. So, I mean, this is a tiny polyp. It looks hugely magnified, but also it obstructs your views. With hysteroscopy, all you have is 3 polyps sitting in front of your eye. When you press the suction, you see that fluid coming towards you. It is bloody fluid and so on. But then you just sit still. You don't do anything. And then you give it a second, the picture becomes good. This is every time you press the suction, it collapses. You see the septum has narrowed down some now. And the fibrous, and you're taking the endometrium on its surface, so you're seeing more fibrous tissue. The top, this is either a polyp or just thickened endometrium. You really can't tell except when you send it to pathology, whether it was true polyp or just So now you've seen the septum. I didn't do anything. You just hold still for a second. The septum is still there. So we're doing that. The cornea is, one cornea is here. I got you different videos because I said if I put one long video of a case, everybody will be deep asleep by the end of the So don't worry, each is 3 to 4 minutes. By the time you doze off, I mean, I'm ready for the next one. Now I move to the right side. So you see this is there. So this is a tool that uses mechanical energy. So this is not electricity, but you can use a monopolar current or a bipolar current or laser or scissors. And you will see me using different equipment and different. And at some time when we it's thinning, you can see now, I mean, it was like as wide as that, now it is like that. We come to the point where it breaks that through. And then we thinned it out so much. This is regular hysteroscopic scissors, and we cut it. After we cut it, we will get the instrument again and remove the 2 parts that are cut. Why do we remove 2 parts? For 2 reasons. Number one, that you're leaving behind fibrous tissue, so if it implants on that, it will not take. Or it could take if she's lucky, like if it implants half here and half on the normal, it would. But if she's just unlucky, and the whole embryo is, as you know, very small, if it sticks here, how much chance does she have? Zero chance. So we're cutting with the scissors. The scissors has one side is fixed and the other side opens, and we cut. You keep cutting. You see, all that is fibrous tissue. Did it bleed? No. We were cutting with the scissors, and it doesn't bleed until you see those holes. Now we're getting to the fundus, the muscle of the. If you continue, it's not. I mean, even if you make a hole at the end, it's no big deal because you're done with the case. But if you make a hole at the very beginning, the water will leak into the perineal cavity. You will not see. So you will have to quit and come another time. But so here it is. You see the difference in density. This is very dense white. Here we thinned it out. So I thinned this more than that. So you have to, and then you have to remove that. If you don't remove that, 2 things could happen. Number one, implantation still occurs there, and she will miscarry again. Number 2 is that it reforms. If there is enough fibrous tissue and the uterus collapses, and if you look at those hysteroscopies that you do every day, 5 minutes after you're done with the case. I mean, you do whatever you do and so on, and just give it 5 minutes, go and chat outside and come back and put your scope again. It is just filled with almost a blood clot. I mean, almost a blood. Give it 5 minutes from the time you're done before you take your gloves off and just let somebody else put the scope in. You will see it filled with clot. And if you leave it, that clot could give it a chance to close together again. And I'll show you in another time cases that we have done it once and then went and looked again, and when we looked again, we found it almost completely closed. And then others, we took out, I mean, when you have a big septum, we took out a significant amount, and when we come again, we look. So this is a septum. This one, I think this one is a fibroid. Yeah, this was a fibroid. So this is a submucosal fibroid. This is the cornea. You've seen the cornea on this side. This is the fibroid that we pulled back. And then, we are removing the fibroid. So this is a hysteroscopic removal of submucosal fibroid, or basically hysteroscopic myomectomy. So you will see it's eating it up. Once it eats the surface is smooth, so it could slip. I mean, this case did not slip, but it could slip until we get it, and then once it eats inside, it eats. I mean, there is different sizes to this equipment. So this is the XL. The XL could remove up to 5 grams of tissue per minute, which is a significant amount. But this is a myoma, of course, well edited, because the whole procedure took 4 minutes. I mean, it takes about 15 minutes for a fibroid. It could take for a septum a short or a long time, depending whether you cut more or you remove more. The more you remove, the more it takes time. But this is a submucosal hysteroscopic resection of fibroid. You can see that the fibroids there is no rule. I mean, you can have one and then another small one on top of it, just sitting on top of it. So now we're tackling it from the undersurface. But all done under complete visibility and removing the tissue. And like I said, this is an XL, so the XL removes the tissue at approximately 5 grams per minute. This is the inside of the fibroid. The fibroid will also have feeder vessel at the end. Many times it doesn't bleed. If it bleeds, you can just apply pressure until it stops, or if it bleeds too much, you can coagulate it, of course. I mean, in many, I mean, we have done approximately 150 uterine septum and fibroids, and in all the group of in all the cases, we had one case of a large left cornuate fibroid that the feeder vessel kept bleeding. So we had to go in at the same time after we finished and coagulate it. If we didn't coagulate it, we had access to robotic. We can go in and from outside and put a suture. But this is from inside. Okay. The more angry at it, the quicker it goes. I mean, the more gentle and so on. You know, you can. So you have to get a little bit angry at the fibroids. So actually, you have to dig. And similar with the septum. I mean, if you apply it at the surface of the septum like that, it slips. But then at some point, you have to poke it in and so on. Of course, don't poke with the scissors much, because the scissors is sharper than you think. I mean, those tiniest 3mm scissors look benign, but they actually could cut and cut and cut. There is many equipment for that, and actually I wish for all of you, definitely for all our residents, to go to one of the national hysteroscopic courses or laparoscopic course. I mean, you would like to think that you, I mean, we do a variety. I mean, we do probably 3 techniques. But nationwide there is 5 or 6 techniques. You go to those courses, you see an extreme variety. Your head gets integrated with the information. So when you apply cases, you would find it immediately changes your practice. But I mean, we can show you at least 3 techniques that we do regularly. One technique is the removal using, this is mechanical energy, so there is no electric energy. And the second technique is the scissors, and the third degree is resection using a resectoscope with a monopolar car. There is other resectoscopes. There are 3 resectoscopes available worldwide. There is one other resectoscope that is bipolar. The difference between the monopolar and bipolar is that with monopolar you have to use glycine. With bipolar you can use normal saline. Of course, there is a big difference because we are rinsing that cavity throughout, and if you use glycine, it gets absorbed. It could give them pulmonary edema that is difficult to treat. If you use saline, it still could be absorbed when you open the tissue, but it's saline, so you can give her Rizk and it will be cured. So this is the fibroid. I hope that we show you at the end. When you suction, again, it pulls. So the suction is a very high pressure. It's from 200 to 800. So it pulls the blood, so the picture becomes tough. You take your foot off, it gets clear. So this is the fibroid. And this is the end of the cavity, so the end of the procedure. Just leaving you a white space there and so on. So what happens with that? We give her some estrogen and it clears. Do we put, I mean, it's close to the end. Do we put IUDs? I do not put IUDs, but many people put an IUD at the end of the procedure. Many people put a Foley catheter in the uterus at the end of the procedure. I mean, we don't use either. Let me show you another quick one before you go to your busy work. So this is what? Septum. Excellent. Right cornea, left cornea. Where is the septum? Here. It always is like that. Why is it like that? Because the 2 sides came together and just the wall didn't fit. It's like this wall and another room there. You can take the wall from down, but then if you leave the top part of the wall and take it from here down, then we're looking from here to upwards. So this is your septum here. And again, we'll use the combination. So this is the instrument. I sometimes, I mean, it is very difficult to remove a tissue that is vertical inside the uterus. It's very easy to use it to remove a fibroid, because fibroid like that, you put it on the surface, it eats it up. You use it like that, you put it on the side, it slips. So it actually took a lot of time to develop. That has not even been nationally reported. Like we've reported the first case of removing Sherman Syndrome is in the ASRM, the American Society for Reproductive Medicine. It's in the video session this year, next month. It is the first case of normalizing the uterus with an Sherman Syndrome, following, using tissue removal device. And also we just reported to the SGS the first one of removing uterine septum using those device. I mean, this is not typically done because most people would cut it. And cutting it is okay. But of course, there's 2 problems. The monopolar current could be problematic if you make a hole, and of course you have a chance of burning the bowel if the bowel was adherent to the outside. The second problem is that you use glycine, and glycine could be hazardous in itself, and also the visibility with glycine is very turbid. If you put a drop of blood there, it becomes like molasses in the glycine. With the normal thing, it washes and washes and washes. In upstate New York, one of the gynecologists is renowned for cutting those with laser. I mean, he's been doing that for literally 30 years now, almost. And most of them we exchange. I mean, we exchange cases. These are all our cases from here, from Mobile. But some of the cases that I'll show you in another time would be like using laser to cut those. And here we're putting it inside. But the more you see of this bit, the more that means that I'm doing nothing. I'm failing to cut. The more this part disappears, I mean it's across the tissue, so it eats it up. So here, what I'm doing, I'm changing the angle. So the septum is like that. If I put it across, it just goes up and down, up and down. So I put it to 45 degrees to eat this bit. Once I made a hole there, a crater, I go to the other side and make another crater. You stretch it more, and then it goes through. But it is removing septum is different from cutting septum. Anybody could go in and slice it, and then you look again, you find that there is a recurrence rate and there is a failure rate. So failure rate means that if you look 1 week later, it's still there. Recurrence rate means that you have evidence. Like, I mean, I'll show you later cases that we have cleared the uterus until the top is one straight line instead of having a 5-6 centimeter septum. And then we look at it 3 months later and we find there is at least 1 or 2 centimeters. So it wasn't fake. I mean, we still have the first video. So we go again. But some of those septums are huge. And the muscle and fibrous tissues are dense. It's dense fibromuscular tissue. So this is the same. I think I ended that for your time, and I'll just show you one more. I don't know if this is the same one. Yeah, this is I think another fibroid. So here visibility is beautiful. You have, this is the right side, this is the left side. What kind of fibroid is that? Submucosal. Submucosal. Don't be afraid. If you say it wrong, there is no penalties whatsoever. As a matter of fact, if you see those, even when you take your exams, you find that the exams are much easier. It's very difficult to retain an absolute amount of abstract information that you haven't seen. But next week is endometriosis. I'll show you some pictures. I'll show you also hopefully some videos of like hysterectomies in people with adenomyosis, like adenomyomas, literally the size of grapefruits and so on, and how we take them. We had somebody like last week at Mobile Firm with like 5 ovarian endometriomas. Each ovarian endometrioma is a grapefruit size. And the 2 ovaries are flipped on each other, closing the cul-de-sac, and then the bowel, the sigmoid and colon is covering them. So I have to take those down and then go. If you do just remove the ovaries, then she will, of course, not be able to pregnant. So here you have a 34-year-old that wants to have this. So we had to literally peel those out. I'll show you some of those videos next week. But here is the same principle. Again, you see, this is applied. You can see here it's much easier with a fibroid. But because it's coming out, you have a surface, you're just laying it across the surface. It's very difficult when you have like if I tell you there is the cornea of the uterus, you want to shave that cornea there. Once the tissue is grabbed inside it, the suction is incredible. Once it is grabbed inside the tissue. And here we think we're doing well because you're not seeing my instrument rotating. If you see the light inside that instrument going up and down, means there is no surface application. And then I always do 2 things. When you go inside, we do not dilate the cervix. There is nothing called cervical dilatation. We put the hysteroscope and put water until it falls inside. You start dilating the cervix, 2 things happen. Number 1, the water falls out. Water falls out, you don't see. Number 2, you go wrong up or down. How frequent? Very frequent. In a routine D&C, it doesn't matter. But in a case like that, where it all relies on visibility, you can't poke things. So we will give them cytotech before, and we put the hysteroscope in the cervix, and just leave it to run the water and talk for a minute or so. It would go inside. What it happens, if it doesn't go, you can see a ridge in the back and the front. I get this instrument and clean out the cervix, correct the topography of the cervix. How many times you have a cervix that you go left and then right and then left and so on? By the way, Emily did yesterday three hysteroscopies. I thought that we can never get in those services, but somehow she navigated the Olympus left and right and up and down, and then indulged inside the endometrial cavity. So I must say that was pretty good.
But sometimes you go in the cervix, you can't go. I mean, the cervix, goes to the right and then down and then to the left. I mean, you can't. So you start dilating, you have to dilate it to 12 millimeter or something like that to be able to put an instrument. You cannot dilate the cervix. So you can, but you've lost the case because it will leak water. All right, I think I've showed you those, but this is the end product. Of course, this is a normal cavity. No, it is the same case. So this is the end product. I hope you enjoyed the movies if you didn't enjoy the lecture, and I hope you enjoyed both. Yeah. And I will see you next week. So next week is endometriosis.